Before I introduce our guest speaker, I would just like to remind you of the general rules. Please make sure that your mic is muted. I saw at least 2 or 3 people whose mics weren't muted, so please just make sure that it is. And if you would like to ask a question, please make use of the chat function at the bottom. So without any further delay, I would like to introduce our guest speaker for today, Dr. Chanel Changfoot. She currently works as a senior registrar in surgery with a special interest in trauma surgery at Tygerberg Hospital. The topic for today is bowel obstruction. Thank you so much, Dr. Changfoot, for doing this for us.
Okay, thank you again, Sas, for arranging it, and for all of you giving up your Saturday. I enjoy your company. I enjoy giving this, these kind of topics to you guys. So please communicate with Sas if there's other topics you want. If it's not my field, then I'm sure I can rope in a couple of friends who would be interested in giving you guys topics. Very important for me. I know it's so difficult online, but I really want this to be interactive. I've mentioned before already, there's so many online resources that to make this stand out, it's important that it's useful for you in your setting and on your level. So it's important to ask questions. If you don't understand something, please stop me. I unfortunately can't see your faces because normally I can kind of register if there's like, you know, nodding or concerned frowns. So I don't have that luxury anymore. It's very important, please, that you guys ask questions. I'm going to try not stop during the talk, but we can address all of it at the end of the talk. If you feel more comfortable perhaps verbalizing your question, then in the chat function, please just put your name in, and then when I call it out at the end, then please unmute and we can actually have a conversation if it's difficult for you to type the question. All right, so as you all know, I've worked at Tygerberg for a long time. I'm now doing trauma work in public and in private. But from my reg days, I do remember a little bit about bowel obstruction. So it's a very big topic in general surgery. It's something you're going to see in adults and in children across the board during your time as a doctor. So although you need to understand and study what the causes are, again, it is so important to actually understand what you are seeing and why, because then you will know how to approach the patient. So again, very important. It's not so much about furiously scribbling down notes and trying to, you know, take pictures of the PowerPoint. You will have access to it. It's about understanding. There's not that much information on the slides. It's more about understanding the concepts. Okie dokie, so let's roll. All right, so bowel obstruction, how we're going to approach it. We're first going to look at the anatomy of the gut. Again, this is not an in-depth anatomy discussion. This is useful anatomy because that's all I can remember. All right. Then the approach, how we are thinking about the problem so that we know how to manage the patient and how quickly we need to react. Pathophysiology, why are we seeing what we see? Always very important for me. And the most important thing, how are we going to manage this patient? Now that slide is actually only, or that topic is actually only 1 slide long. So that is why I want to illustrate it's so important to understand, because the management is kind of cut and paste. Most of them are going to get the same thing. But if you know what is going on inside, you know what needs to be done additionally. Okay, so just the anatomy of the GIT, we are going to be talking about small and large bowel obstruction. So we're interested in the yellow and the pink. All right, what I want to illustrate here, this is from Netters, we all have access to it, is you see how the small bowel is folded. All right, that is the mesenteric attachment and it's folded in almost like a zigzag pattern. So it's folded in almost like a zigzag pattern. These are in normal patients, okay? So about 70–80% of patients. I don't want to give too much away, but there are those patients where the mesentery isn't folded in that normal zigzag pattern. So the small bowel cannot really flop around that much. Okay, so just looking at our small bowel again, we have our duodenum, which is very fixed in the retroperitoneum. That's not very exciting. Then that becomes our jejunum at the ligament of Treitz. That's a couple of meters, and then we go to our ileum, which goes to, very important here, where the small bowel and the large bowel change over, and that is at the ileocecal valve. Okay, that is a very important anatomical point to remember. And then it's large bowel. Okay, so here's just an example of our small bowel. You can see it's nice little blood vessels running in the mesentery. Okay, so if we zoom in a little bit on our small bowel, you can ignore the really small pictures, but look at the vessels running into the small bowel. You have an arterial supply, you have a venous supply, and that runs right into the villus. Okay, so if we zoom in even closer, remember this is not so important on a surgical level. You guys had to know this in second year, third year, but you do actually know it's got the muscular layers. But important to see that there's an artery running in, a vein running out, nerve supply, obviously because there's muscle and muscle needs to be told what to do. So there is a nerve supply. And very important that we forget is this little green pipe. And what is always illustrated in green? The lymphatic supply. Okay. So there's actually 3 vessels that run into every structure: artery, vein, lymphatics. Okay, and we need to remember that the lymphatics actually do a lot of fluid mopping up that we don't realize. So if you think about it like a venous stasis leg, you know, where you have that big swollen leg, if you have venous stasis in the gut, same type of thing happens, we just can't see it. So that's important to remember for later. All right. Then we're moving on to our colon. Again, not in-depth anatomy. Here's our ileocecal valve. It runs into the cecum, ascending colon, transverse colon, descending colon. Okay, rectum is its own special little area. It's not part of the colon. Okay, so remember, depending on the patient's body shape, genetics, these can be varying lengths. So you can have the transverse colon hanging right down into the pelvis. You can have a very short ascending colon that's 4 or 5 centimeters. So this is just a broad overview of what a colon should look like. But except for the transverse colon, which hangs like a bit of a curtain here down the middle, the ascending colon is quite fixed to the abdomen, descending colon quite fixed. Sigmoid, that is free and floppy. Okay. Okay, just again looking at our blood supply. So it's a lot, how can I put it, less petite than what the small bowel supply is. So this colon, or this side of the colon, has a nice big vessel running there. This one has a nice big vessel. It doesn't have those specific small little vessels that run every couple of millimeters like in the small bowel. So more gross arterial supply, if I can put it like that. Okay, but that's all very pretty, and one day when you're teaching students, you're going to draw them beautiful pictures of that. But when we are discussing bowel obstruction, we are discussing it in terms of, is it small bowel obstruction or large bowel obstruction? Okay, so this is the picture ultimately that you need to have in your head. Okay, so now let's look at how bowel should normally function. So normally you have peristalsis, okay, muscles, moving content, food, whatever you eat through an open tube. Okay, that is the definition of normal bowel function. So there needs to be contraction from a nerve supply. There needs to be relaxation also from a nerve supply. Remember, for normal nerve and muscular function, the electrolytes need to be normal. All of that needs to be normal. The content needs to be able to fit through the tube, and the tube needs to be open. Okay, so it's kind of 3 things that we require for normal bowel function. So obviously, if there is disease, it can only be in one of those 3 functions where there's an issue. So if you have that idea in your head, it's so much easier to come up with a differential for bowel obstruction. So there's either no peristalsis. We're not going to go into too much detail about that now. The contents are too big. Okay, so for example, if you swallowed a shoe, okay, it's just physics. Or the tube is not open or not open enough. Okay, and that is what causes bowel obstruction. Okay, so now you have to think, is lack of peristalsis really a bowel obstruction? Maybe not 100%, but it will look very similar. Okay, and this is often what we refer to as an ileus or a pseudo-obstruction. Okay, so it's not exactly a bowel obstruction, but some textbooks will call it a functional bowel obstruction. It's because there's not proper function that the bowel is looking obstructed. Okay. So now we go to the causes of the pathology. So again, we're starting big and we're taking a finer approach. So why are you not going to have paracelsus? You have electrolyte issues, and then you have to think about what the causes of that are. Is there sepsis? Remember, that causes electrolyte issues. It causes inflammatory cytokines. If there's pus floating around in the abdomen, the bowel is not happy to be lying in pus. Is it medications? Something that we're giving the patient, something that the patient is taking for other reasons? Is there disease in the musculature or in the innervation? Okay, and there are chronic and acute diseases that affect that. All right, content. Did they ingest a foreign body? Okay, people who eat hair or have pica and eat strange things. Or is it high density contents like a worm bolus or a gallstone? Okay, and then is the tube not open? So is it being pushed closed from the outside by a hernia or adhesion? Is it being grown closed by a malignancy, or are there other causes? So when someone asks you about what your approach is to bowel obstruction, there are a couple you can take. You can either diagnose it anatomically, and we've already said we're going to look at small bowel versus large bowel. You can diagnose it or classify it, is it mechanical or functional? Okay, but I don't think that's a great one, because we've already said functional is kind of a small topic. And then you can diagnose it between where the issue is. So what Prof. Warren used to teach, if this is your bowel, and nice thick bowel wall that we're seeing here, is it a problem inside the gut? So there again, we're talking about contents are too big, or something like that. Is it an issue in the wall? Okay, like a cancer that's growing in the wall, or a stricture that is narrowing the wall so that normal contents are not able to pass through? Or is it an issue outside the wall where something is pushing it closed, or it's in an area that's pushing it closed? It's being grown closed by adhesion. There's a cancer that is pushing the tube closed. So there are various ways that you can classify bowel obstruction. And again, it has to be what makes sense in your head. None of the descriptions that I've described or that I've mentioned are wrong. It all just depends on what makes sense in your head. Okay, so an inside wall and outside concept works quite well. Okay, but what is the most important cause of bowel obstruction? So Prof. Warren will always say bande en breuke. So to translate, it's bands and hernias. All right, but it very much depends on the type of patient that you're seeing, the age of the patient. Okay, but most of the bowel obstructions we see are because of bands, which are adhesions, and hernias. Okay, so if we just look at the picture, a hernia, we can see that's causing an obstruction. Adhesions, a volvulus, not really mentioned, intussusception. Okay, so here this is an outside issue, this is probably an outside issue, and this you can classify kind of as an inside or an outside issue. But yeah, so this is all very interesting, but why do we actually care about bowel obstruction, and why, if you see a bowel obstruction, do you need to manage it immediately? Okay, so yes, malnutrition is an issue, but most humans have reserves of up to 7 days. So, you know, you don't really need to eat. Okay, food not getting from point A to point B is not the major concern at this point. Okay, but if you have a patient that has chronic obstructive issues or subacute, you know, it's not that bad that it's total obstruction, but they're chronically malnourished, cachexia can be something to think about. Fluid loss is a big problem, okay? And I want you to understand where you are losing fluid. So there are two mechanisms, three mechanisms. First of all, you're vomiting, okay? So you are actually losing fluid out of your body. Your gut is not absorbing because the contents are not moving adequately through, okay? So even if you take water in, the absorption is an issue. And you are also losing fluid into the third space. So where is the third space? The third space means it's not in the cell and it's not in the vasculature, okay? It's floating around those things. And if it is not in the cell or in the vasculature, it is not of use to the body, okay? So with bowel obstruction, there's actually sweating of fluid from that angry obstructed bowel, from that mesentery. It's being sweat into the peritoneal cavity, okay, and into that third space. So patients are dehydrated even though they may have a ton of fluid leaking into their abdomen. It's not accessible fluid, so they are still intravascularly dehydrated. Okay, bowel ischemia. So this is one of the very dangerous issues with bowel obstruction. So when the bowel is obstructed, okay, be it by an adhesion or a hernia, you need to think about, is it just the lumen that is being obstructed, or is the blood supply that's running via the mesentery also obstructed, okay? And that is very dangerous. So that is the difference. Let's just go over some definitions between incarcerated bowel, bowel that is stuck in a position, which is uncomfortable and not great, but not that dangerous, and strangulated bowel, where the blood supply is actually being strangled by whatever is causing the bowel obstruction. Okay. And then something else that is an issue with bowel obstruction is bowel perforation. So you see I noted there local versus distal. So in this picture, we can see there's local risk for perforation. But if you have a closed loop obstruction, so let's just think about it. A closed loop means it's closed on both ends. Remember, bowel has an in point and an out point. So if it is closed on both ends, okay, remembering that a sphincter or a valve can act like a closed end, then all of that bowel between those closed ends will dilate, okay, and with dilatation, what happens is that if you remember the small vessels running into the bowel can actually dilate to such a point that it pushes its own blood vessels closed. All right, if you remember the talk we had previously about crush, compartment syndrome acts very much in the same way. So you are getting a localized compartment syndrome of that bowel. And with that dilatation, okay, you can actually have distal bowel. So not where the obstruction is, but where the most pressure is being compromised. Okay, so we often see that with large bowel obstruction, say a sigmoid cancer, and then they get cecal perforation. Okay, the disease is not at the cecum, it's at the sigmoid. But because the ileocecal valve in the majority of patients, up to 2/3, is actually competent, it acts as a closed loop. So the bowel blows up, blows up, blows up, and because of the shape and tensile strength of the cecum, it takes most of the pressure, and that is where it actually perforates. Okay, so that is a pressure issue. So if you look at all these things, this is why we need to manage bowel obstruction as quickly and as well as possible. But the last two are what dictate the urgency of management. Okay, so if a patient comes with large bowel obstruction, depending on what the features are, they may only be operated in a day or two. Okay, but if you have an incarcerated strangulated hernia, that is an emergency procedure that needs to happen within hours. Okay, so again, it depends on what the clinical features are of the patient and what you are suspecting is wrong. That will dictate the urgency. Okay, so now let's actually make it useful. We understand more or less what bowel obstruction is, but now let's make it a little bit more real world, because I think that is the most important. Okay, so here we are. You guys are all interns next year at Tygerberg or the R or Kuruman, okay? Small hospitals, you don't have a surgeon on call, and you're also the only doctor on call because that's how it's going to work. So, yeah. So you are called from a peripheral clinic and they say, hi, doctor, just want to let you know I'm sending you a bowel obstruction. The shift before told me, so I don't know anything about the patient, but they said he has a bowel obstruction and he's on the way to you. So good luck. All right. So now how are you going to approach this patient? Okay, and we have our clinical approach. Now this is something that you can template for every disease you're ever going to see. All right, and this is basically the one slide that you need to study off by heart. The rest of the stuff we're discussing today is going to be you clicking and understanding. All right, so most important, before you take out your little clerking book or take your pen out to see a patient, is you are immediately, as you walk towards that patient, going to assess, is this patient stable or unstable? Okay, because that is going to dictate your whole line of management. Good. Okay, because if the patient is stable, then you can talk to them and get their history and what medication are they on. If the patient is unstable, you're immediately going to ABCs. You're not going to ask them about what surgery they've had and how long have they been vomiting. Then the history is irrelevant. You first need to keep them alive to ask them. Okay, but let's assume most patients arrive sick but stable. All right. So important is you need to consider the age of the patient. All right. A 22-year-old male with bowel obstruction should immediately make you think other things versus a 70-year-old female with bowel obstruction. Okay. So yes, you are going to have a full differential in your head, but some things are going to shift up and down the list depending on the age of the patient. All right. So the majority of today's talk will be on adult bowel obstruction. If you have pediatric questions, you can ask specific ones at the end. Okay. Then important to address the complaints of the patient. All right. So if they're telling you, you know, they're actually feeling okay, they just feel very bloated, you're going to start thinking other things than, oh, doctor, I've been vomiting green for 2 days. All right. And if you remember the anatomy of the bowel, you understand why that's happening and where you are kind of focusing your differential at that point. History, always important. Medical, what medications they're on, okay? Because we're trying to also think about the 3 pathologies of bowel obstruction. Are they maybe on drugs that could be causing this picture? Do they have a surgical history? Have they had multiple laparotomies? Have they been to a surgeon recently for a surgical complaint? Do they have a family history? Okay. And this is more tailored with a history of malignancy. All right, then examination, we're going to go for a general examination, and then in obviously a surgical talk, we're going to go for a focused abdominal examination. Remember, an abdominal examination includes all of the hernia sites and a rectal. If you don't put your finger in it, you put your foot in it. Okay. Then at this point, already you should be able to formulate a differential. Okay, 80% of your diagnosis should be made at this point. Okay, then if you still need confirmation, and there will be those cases, you go for appropriate investigation. Now, assuming you are in a small district hospital, you're only going to have x-rays. So we're going to focus on those diagnoses. Okay, anybody can scan somebody and read the radiologist report. Okay, but x-rays, we don't always get those interpreted. It's important to recognize basic signs. Okay, so now your patient arrives and you need to decide, is this a small bowel issue or a large bowel issue? And using your clinical approach, you should be able to get to that answer. Okay. Okay, so now let's discuss small bowel obstruction a little bit. So again, we're thinking no peristalsis. Is the content too big or is the tube not open? So if we go there, no peristalsis. So electrolyte issues, is there sepsis? Okay, so this can be a pneumonia, or it can be an appendicitis with an abdomen full of pus. Okay, any sepsis can cause an ileus. Have they been put on medications, or are they taking over-the-counter medications that could be causing this? Something patients take regularly, Buscopan. They've been having cramps, so they took Buscopan. Too much Buscopan is going to stop the cramps, but also all bowel function. Okay. And then, do they have diseased musculature or innervation? So ADLM is African degenerative leiomyopathy, okay? Seen obviously in African patients. Leiomyopathy, so that's the smooth muscle. It's a disease of the smooth muscle, okay? And it can affect the esophagus, the stomach, the small bowel, the large bowel, and what happens is there's just no peristalsis, okay? That has quite particular presentation, but it's just something to know about, that it can actually be a disease of the nerves and the muscle. Not well recognized, not easily diagnosed, not something that needs to be very high on your list of differential. But again, if we're thinking according to those three categories, it will automatically come up. Okay, then we're thinking content too big. So foreign body ingestion, so a bezoar, that can be formed by indigestible content. So people who chew their own hair, they actually form a little hairball in their stomach, and that can cause obstruction distally. Okay, worm bolus, okay, seen in kids. The worms kind of all clump together, and then it creates a mechanical obstruction. Prickly pear, so this is something we saw in the Northern Cape. It has those little indigestible seeds or pomegranate seeds. And again, that just clumps together. Okay. And then hernias. So I put this under the tube not open category because the tube is actually pushed closed as it goes through the hernia orifice. So that orifice where the tube is acts as the compression adhesions. So this can be surgical, like they've had previous surgery, Caesars, laparotomies, inflammatory, so this can be from inflammatory bowel diseases like Crohn's, that can cause adhesions. If they had previous sepsis in the abdomen, any bacterial peritonitis, PID can cause it. What is the other thing? TB abdomen can cause it. And then a Meckel's. So if you remember a Meckel's, it's a little extra diverticulum that hangs off of the small bowel, and depending on what the end has grown attached to, that can act as a band that the small bowel sits underneath. Okay, volvulus. So this is not something that we see often in the small bowel. Okay, why? Because it has that, the small bowel has that zigzag pattern in the mesentery that fixes it to the retroperitoneum. So in which patients could be prone to a small bowel volvulus? And this is deadly in most of the cases. So if you think about patients who have congenital malformations of their gut, okay, the midgut malrotations, because these patients don't have the small bowel fixed in that nice little zigzag pattern, okay, it's hanging off its mesentery. So that mesentery can easily twist around, okay, and they get a midgut volvulus. So if they are not operated in time, all of their small bowel die, okay, and that is not survivable. So very important to think about volvulus as well, even if the patient doesn't have a history. Remember, they may not have been diagnosed as a child, they may not have presented with any issues, or everybody ignored their issues. Okay, then malignancy. So malignancy primarily of the small bowel is very, very rare, okay? But it does exist. It's not going to be top of your list. But again, think about the presentation. Has this patient had worsening weight loss, worsening pain? Because remember, a malignancy doesn't pop up as a cancer one day. It's a thing that grows gradually, okay? So there in the small bowel, you're thinking about your lymphomas, you're thinking about your carcinoid tumors. But also remember that malignancies in other organs push on the small bowel. Okay, so your ovarian malignancies, your colon malignancy, it's all one shared space. So it can be an outside malignancy pushing on the small bowel. Right. So the order that this differential is going to come up in your head will be based on what the history is from the patient and what clinical findings you have. Okay, so now let's think. Okay, we have our clinical approach. We're going to template it. So we're going to go to complaints regarding the small bowel. Let me use my little thingy here. All right. So complaints. They're going to have nausea and they're going to have vomiting. Okay. What are they going to vomit up? It will usually be green content because there's bile involved. Okay. Small bowel content is usually green. They have early satiety. Why? Because their bowel loops are full of content, so they're not hungry. They may have varying levels of distension. Why? Because it depends on where the obstruction is. If the obstruction is 30 centimeters into the small bowel, there's not that much to be obstructed. But if it's right at the distal ileum, okay, then all of that small bowel is going to be distended and swell up. So it depends on where the level of obstruction is. Okay, they're going to have cramping. Why? Because the body is trying to overcome this obstruction. Okay, even if it's a cancer, the body doesn't know that. So it's going to be trying to push the content past the obstruction. So that is why they have that cramping feeling. Okay. They will not have it with ileus because the bowel is just lying there. It's not doing anything. So they will not have any cramping with ileus. Okay, and then they say, oh, there's a new swelling, or I've got a pain in my groin. Okay, the problem is often patients will be so focused on the vomiting and the cramping that they neglect to mention that, oh, they've got this egg-shaped mass in their groin. Okay, so if they don't complain about it, you need to ask. Okay, have they had any surgery before? Why? Because we're thinking about adhesion. Did it begin with right iliac fossa pain? You know, is it maybe an appendix? Did it begin with epigastric pain? Is it maybe a perforated ulcer with an abdomen full of pus? Are they known with a hernia that they should have had surgery for, but they've been delaying it? Okay. Then suddenly they'll remember, oh, yeah, no, I have a huge hernia. Oh, yes, it's actually swollen, but actually I'm vomiting. They will focus on the vomit. All right. So you see how already based on the patient's complaints and history, you have a differential in your head. Then when you do your examination, you're either trying to agree with the differential or disprove the differential. That is why the only thing a person really needs to study in surgery is the differential, because then you can decide what fits in or not. Okay, so when you see this patient, assuming they are stable, they are going to be in pain, okay, because the cramping is constant. They're going to be squirming around on the bed. Why is this important? Because this is versus a peritonitic patient who doesn't want to move. Okay. You know, when you have gastro and stomach cramps, you're kind of wiggling around trying to find the most comfortable position. Okay. There will be a degree of dehydration depending on how long they took to present. And this will manifest, of course, in their skin turgor. I don't need to go over that with you guys. Elevated heart rate. Blood pressure can be up or down depending on pain and how dehydrated they are. Sweaty, diaphoretic, they are uncomfortable looking. Okay, so then we do our cardiovascular, our rest exam. Not going to go into that now. We do our focused abdominal exam. We're going to look, listen, and feel. All right, basic surgical stuff. What are we going to see? We're going to see a distended abdomen, maybe, depending on the level of obstruction. If they are nice and skinny, you will actually be able to see visible peristalsis. You can see the proximal bowel trying to kick against this obstruction. Okay, you're going to have increased bowel sound. Why? Because the proximal bowel is hyperactive, again, trying to overcome this obstruction. Okay, they will have tenderness everywhere, not in a specific place usually. They're just sorish everywhere. Okay. So globally tender, but not peritonitic. Then you may see a hernia. Remember, you're going, part of your focus examination is to examine all of the hernia sites. You'll see a hernia. You'll feel a swelling there that you can't get back in. And very worrying is if there's redness. Okay, redness means inflammation or sepsis. If there's inflammation or sepsis, it means that bowel is compromised. Okay, and the bacteria is probably starting to leak out of it if it hasn't already perforated. I put peritonism here because that is a very bad sign, okay, and a late sign. So that means they have a bowel obstruction, but there has already been perforation, okay. Only at that point will they have peritonism. Clear, simple bowel obstruction will not have peritonism unless the bowel is ischemic or has perforated because of those other things. Okay, everybody happy with this so far? You understand what you're going to look for and why. Okay, so now we're moving on to large bowel obstruction. This is something that you will usually only see in the older population, okay? But if you see it in a younger patient, it is very concerning because there are not a lot of benign causes for large bowel obstruction. If you think about the large bowel, remember the caliber, remember how distensible it is. Okay, it takes a lot to obstruct a nice big pipe like that. Okay, so what are our causes? Okay, you're in your exam, the examiner says, okay, causes of large bowel obstruction. And what does your brain do? Hits a blank. That's okay, you go to your 3 categories. No peristalsis, content issue, or tube issue. And then you just run through that in your mind. So again, electrolyte issues. Remember the bowel has similar musculature all the way through, so similar issues will affect it. Sepsis, again, those are your ileus type of causes. Medications, remember the elderly are on a lot of medication. Something else that affects the large bowel quite a bit is your antipsychotic drugs. Okay, and what do we love to give patients who are in pain? Morphine. Okay, morphine classically associated with constipation and ileus and those sort of complaints. So important to know the medical history of the patient. Okay, diseased musculature, innervation, again, your African degenerative leiomyopathy. What we see in these patients is it normally starts at the colon. They get worse and worse colon distension. We cut that out. Then they start developing small bowel distension, and then it just takes over the entire GIT. And we don't really know the cause of it, and we don't actually at the moment have management for it except to cut out the diseased bowel. H's, that is Hirschsprung's disease. Okay, so remember, if you have short segment Hirschsprung's, you may not have been picked up as a child. They may just have labeled it as chronic constipation. Okay, but Hirschsprung's, if you remember, is a failure of migration of the innervation. Okay, so innervation starts from the mouth and goes towards the butt. Okay, so if those little innervation cells don't migrate all the way distally the way they should, you get Hirschsprung's disease, which is basically just an area of large bowel that is not innervated. So this is important, again, why we're taking age into account in very young children presenting with chronic constipation, presenting with this large bowel obstruction picture. Okay, pseudo-obstruction, so that's just a fancy way to say ileus, okay? One of the named conditions is Ogilvy's. So that is a pseudo-obstruction of the large bowel. How that looks a little bit different from ileus is it normally has a transition point. So you can see normal bowel and then you see dilated bowel, and then it looks like that transition point is where the obstruction is. But when you go and operate these patients or scope these patients, you'll see there's no obstruction there. So instead of it being a global ileus, which we usually see, it's just normally the descending colon that for some reason is just not functional. Okay, and we see that with older patients, sick patients who have been in hospital for a while, patients on antipsychotics, patients who have been bedridden, your older frail patients. Okay, but that is last on your list after you've disproved all the other causes of ileus and obstruction. And it's just supportive management until that bowel decides to start working again. Okay, so those are all the causes why we could possibly not have peristalsis in the large bowel. Okay, then we're thinking content too big. So again, foreign body ingestion, a bezoar, high density contents, prickly pears, older patients who are on very high fiber diets to try and prevent constipation, they may not have good force of movement, and that high fiber diet actually acts as a obstructive body. Okay, so diet important to consider. And fecal impaction. Okay, it's not that the contents are too big, it's just that the peristalsis isn't good and the contents are a little bit hard, so it can act as a kind of obstruction. So in the elderly, again, fecal impaction is an important one to consider. Okay, then tube not open. So here I put adhesions, because even though you can have a patient with terrible adhesions in the abdomen, it very rarely influences the large bowel. Now, you know, in medicine, you never say never, but it very rarely actually impacts the large bowel. Again, because it's quite fixed, it's on the periphery of the abdomen, and it's a large caliber tube. So you do get inflammatory adhesions or inflammation causing obstructive lesions. And this we see especially around the sigmoid, where they have recurrent bouts of diverticulitis. Okay, so diverticular with recurrent inflammation can actually form adhesions and strictures and narrow that lumen considerably. Big issue in the large bowel is volvulus. So remember, we said most of the large bowel is actually quite fixed. Transverse colon, not fixed. Sigmoid colon, not fixed. So a volvulus of the sigmoid colon, where it twists on itself, creates that closed loop obstruction, also twists its own blood supply closed, we see, and that is very dangerous. Bearing in mind, the length of the sigmoid mesocolon is genetically determined. So depending on what your patient's phenotype is, that will make you more or less suspicious. Okay, so African males, very high risk. White males, low risk. Okay, colored males, intermediate risk. So also something to bear in mind if you see a young patient previously well, suddenly with massive dissension and large bowel obstruction. And most important in the large bowel is to exclude malignancy. Okay, even if there are no other features, you need to exclude malignancy, because we are seeing it so commonly, and we're seeing it in younger and younger patients. Okay, so you have this whole list in your head, how you're going to narrow it down. You're going to go for your clinical approach. So again, we start with complaints. Nausea. Yeah, often pretty much anything goes on in the abdomen, you're going to have nausea. But vomiting is not a big feature of large bowel obstruction. Okay, and this is two reasons. One, the majority of patients, about 2/3 of patients, have a competent ileocecal bowel. So what that is saying is it's one way. Okay, even if the large bowel is massively obstructed, that poo cannot reflux back into the small bowel. Okay, and even if it's right at the cecum, it can be a one-way valve, and it's very distal for all of that small bowel content to backtrack all the way to the stomach for you to vomit it up. Okay, so distension, that is a very prominent thing related to large bowel obstruction. And you also want to note if it's gradual, because that's what you see with the volvulus. They were fine, had a nice six-pack, and then suddenly, whoop, Michelin man. Okay, because that's what you see with a volvulus. Sudden versus gradual, where it's like a cancer or an inflammatory stricture growing more and more closed, and then they get more and more distended as the content can't pass that obstruction. Cramping, they may have cramping, okay, or if they have had gradual worsening of this obstruction, they may not have any cramping because it's been so gradual. Okay, constipation or obstipation, let's just go through the definitions of that. Constipation means you are not passing stools adequately. Obstipation means you're not passing anything. Not wind, not flatus, nothing. Okay. So the definition of constipation, I think this is also just something to go into a bit of detail about. Everybody in the Western Cape thinks they are constipated. Okay. And when you ask them what that actually means, they'll say, oh, they only pass stools once a day. Their cousin passes stools 3 times a day. Everybody, every colon rather, let me say, has its own pattern. Okay, the only time it is a problem is if it causes the patient pain. Okay, the stools are very hard or uncomfortable to pass. Okay, or they are actually having features of large bowel obstruction. All right, so some people will pass stools 3 times a day, some people will pass it once in a week. Okay, there is no correct number of stools. It depends on the entire clinical picture, whether the number of stools that are passing or not passing is clinically relevant. Okay, so there is no 100% definition of what constipation is. Okay, and it's important to explain patients to that when they use the word, because they will often use laxatives and just cause more problems. Okay, then when you are exploring the history, remember now we're thinking about large bowel stuff, so we're going to ask large bowel questions. Do they have a history of diverticulosis? Okay, because if they have been diagnosed with that before, it means they could be now having a stricture after recurrent inflammatory bowels or something like that. It doesn't necessarily mean they're having a diverticular issue right now, but it means the diverticular issues in the past have caused this problem. Do they have a history of PR bleeding? Again, that fits in with diverticles or with the malignancy that's been growing there. Do they have symptoms associated with malignancy like loss of weight, loss of appetite? Do they have a history of worsening constipation, more and more difficulty passing stools, a change in the shape of the stools, of the color of the stools, again fitting in with malignancy or a worsening stricture? Okay, and already at that point, you're going to have an idea of, on your list, where is this patient possibly fitting in, what type of bowel obstruction they could have. Then when you see them, again, they're going to be in pain, they're going to have squirming, they will be wriggling around on the bed. Dehydration, not such a prominent feature of large bowel obstruction because the small bowel doesn't, is usually not that affected because it's protected by the ileocecal valve. So you don't have as much third space loss. But your colon is the area where most of your fluid is absorbed, so they could be using fluid in terms of not actually absorbing what they're taking in. Are they wasted? Do they look like they have an underlying malignancy? Then when we do our focused abdominal exam, distension is a big feature of large bowel obstruction because even if there's not that much physical content in, your gas forming bacteria are there. So it tends to be this big balloon type abdomen. Increased bowel sounds, again, the body will try and overcome that obstruction. Global tenderness, you may feel a mass in the abdomen or rectally. They are very resonant because we said big balloon. And again, peritonism, not a classic feature of bowel obstruction, but it can be there, and that is a very bad sign. Okay, so remember, if you are thinking a sigmoid lesion, you're going to check for right iliac fossa pain specifically. Okay, tender cecum is very constant. Okay, and perforation, of course, can happen. Yeah, I think that's okay. So now we get to the management. All right. So it's difficult to fully focus your management unless you have the diagnosis. But in general, you are always going to resuscitate the patient. So ABCs come first, an IV line always, because there's always an element of dehydration. Analgesia is very important. Remember, unless you really sort out the problem, pumping them full of antispasmodics and analgesia is not going to completely get on top of it, but it will help in the acute phase just to make them feel a bit better so that you can institute your management. A full blood count, a UNE, a CMP. I like that because I want to know, is there infection? What is the patient's general state? Is their iron status appropriate? I'm looking at the HP for that. UNE, CMP, I want to look at all of the electrolytes, the most important ones for bowel motility being your potassium, your calcium, your magnesium. Okay. CMP also comes with an albumin, so you know what their nutritional state is like. An ABG, why do I want that? Because it will immediately give me a potassium, to which the bowel is very sensitive, and it will give me a lactate. So I know how metabolically behind this patient is. And a high lactate could also point to perforation and severe sepsis in the abdomen. Okay. And now in terms of making our diagnosis, we also want a chest x-ray and an abdominal x-ray. Okay, that is really going to cinch it for us. At this point, before we even write the x-ray form, we should have an idea. Are we thinking large bowel obstruction or small bowel obstruction? Okay, so now let's think of a couple of specific bowel obstruction managements and whether they're warranted or not. Because although it's good to have a template and an approach to patients, if you are really thinking and applying your mind, which is what we are trying to teach you to do, you're not going to have exactly the same approach for every patient. Okay, then any banana on the street can do your job. Okay, so a nasogastric tube. We always say bowel obstruction, automatically nasogastric tube. But this is actually only warranted in your small bowel obstruction, okay, where you are able to access all of that fluid that is collecting in the small bowel, okay. For a large bowel obstruction, you're not going to be able to decompress the large bowel, okay. You do not have a 4-meter long nasogastric tube. So think about where the obstruction is and whether the nasogastric tube is actually going to be doing what you want it to do. So you want it to decompress that bowel, okay, prevent the patient from vomiting and aspirating, make them feel better, and also decrease the edema in that bowel and the pressure in that bowel. Okay, so again, sometimes a nasogastric tube, not for every bowel obstruction. Okay, you want to know what type of bowel obstruction it is. Okay, antibiotics. Do we want to give antibiotics to every bowel obstruction? No. Okay, only if there is content from the bowel leaking out. So if there is perforation or ischemia, okay, then we want to give antibiotics. To just automatically shoot it at everybody is going to cause more problems than what it's going to help. Okay. Mostly bowel obstructions will require surgery. Okay. Yay. All right. But let's think. Okay. So if the bowel in our large categories, we have the 3 causes for bowel obstruction. If it is a peristaltic issue, okay, is operating that patient going to help? No. Okay. No matter how good the surgeon is, me just looking at the bowel is not going to make it start moving. Okay. I can't motivate the muscles to do it. I can't encourage the nerves to pass the message on. Anesthetics, all of the drugs we give manipulating the bowel worsens that whole peristaltic issue. Bowel gets very lazy after you play with it, okay, which is why we often see a post-op ileus. Okay, then issue number 2, there's an issue in the wall. Okay, so no, it's content, sorry. So if there is a foreign body, okay, I need to think, do I know where it is and can I go take it out? Okay, yes, surgery for that patient. An issue in the wall. So if it's a hernia, then yes, I need to go and take the bowel out of the hernia. I need to close that hernial orifice. I need to maybe cut out the piece of bowel that's been damaged by being in the hernia. So yes, surgery makes sense. Adhesions, depending on how unwell the patient is at that point, how long he's been symptomatic. If we know the cause of the adhesions, oh, this guy's had multiple laparotomies for a stab abdomen or whatever it is, we will normally trial 24 to 48 hours of conservative management. So we do a drip and suck. We give him a drip, IV fluids, we give him a nasogastric to decompress that bowel, and we hope with a decompression and bringing the edema down and just letting the gut rest for 48 hours that it will, the edema will decrease and it will slip free of that adhesion. Okay, so maximum 48 hours. Okay, if it hasn't resolved by then, it's unlikely to resolve, but this is also something that you should discuss with the surgical unit. You should not make that decision. Okay, but it is very important to take a history from this patient and make sure he's actually had surgery. A lot of these patients will have recurrent episodes and they'll tell you, oh no, I get this like once a year, you know, I normally settle down after 2 days. but it also depends on what his clinical state is at that point. This patient has a lactate of 10 and is dehydrated and really, really ill. He doesn't have 48 hours. Okay, then you may opt to go and operate him anyway. But that is one of the few cases of bowel obstruction that we won't rush to operate. Okay. And then, of course, with your large bowel obstruction, if there is concern about ischemia, if there's concern about imminent perforation, if the patient is completely obstructed, then they warrant surgery. Okay, what surgery you do will depend on the condition, but surgical referral is warranted at that point. Okay, so here I just wanted to show you guys a couple of pictures so that you can actually see what it looks like and understand why you're seeing what you're seeing. So remember the two most common causes of small bowel obstruction, bande and breker. So here you can see what the adhesions actually look like. It looks like scar tissue in the abdomen. The longer after surgery, the whiter they become and the softer they become. So eventually they start to look like spider webs. A fresh surgical abdomen, so after 2 or 3 weeks, it's horrible stuff. It's like cement. You don't want to go into there. Okay. So hernias, let's just go over the relevant hernias that you definitely need to exclude. Remember, there's a ton of interesting hernias. Bowel will pop out of wherever it can. But the ones you definitely need to exclude is a umbilical hernia or epigastric hernia. It can be a little bit higher up. Because remember, this is where the umbilical cord went in. So these hernias pop out where there are natural weaknesses or previous holes, even if they're congenital holes. Okay. So your umbilical hernia, easy to pick up. Your direct or indirect inguinal hernia. So you'll feel a mass in the groin or going down into the scrotum or the labia. All right. A direct hernia will be just a little bit higher. A femoral hernia, these are very, very sneaky because they're difficult to feel, they're difficult to diagnose, but generally old, frail ladies. Okay. And here you have a bulge very close to the femoral vessels because they pop out just next to them. Okay. So remember, a inguinal hernia will go into the scrotum or the labia. Femoral hernia is next to that. Okay. And then, of course, an incisional hernia. So wherever we cut into the abdomen, we automatically create an area of weakness. Even if the wound healed well, it's usually only at about 70% of its previous strength, even if you did the best closure ever. So an incisional hernia, always an area of weakness. And remember, it can be in the front, it can be at the back, it can be in the flank. Okay, so be sure to check all of the incisional sites for a mass that you cannot put back. Okay, so large bowel obstruction. In this picture, we see a cancer growing, and you see this little bit of lumen left over. So he may still be able to pass some stools and some platus, but eventually this cancer will grow the entire lumen closed. Sorry, team. Okay, and what we're seeing here is a sigmoid volvulus. This is not full of poo, it's full of air. Okay, and you see how black and angry it is. Okay, because either it's twisted its own blood supply closed because it's a complete twist, or it's so distended that there's not enough pressure for the blood to get all the way from here to there. Okay, so ischemic bowel in bowel obstruction, big problem. Complication, big problem. Okay, so now let's look at a couple of x-rays. So there are specific features you need to look for. When you phone the surgeon at your referral hospital and you give them the case, remember you're trying to sell this patient to them and convince them they must take it because surgeons get very grumpy if you send them extra work, okay? If you give them all of these features that fit in, you use the right terms, there's no way that they cannot accept your patient. Okay, so small bowel obstruction, what are we looking for? Remember, the small bowel tends to be in the middle. Okay, I can't tell you what small bowel this is, but that doesn't matter. It's small bowel. That's all you need to know. You're looking for air fluid levels. Okay, here's multiple. Here's 1, 2, 3, 4, 5, 6. There's multiple. Okay, so more than 2 is multiple. Remember, when you take this X-ray, the bowel is still continuing its motion. Okay, it's a a static picture of a dynamic process. So if you x-ray me now, I may have an air fluid level or two. It's just how you're catching the peristalsis at that specific second. But more than 2 is abnormal with a clinical picture. And then your stacked coin appearance. This is very pathognomic of small bowel obstruction. It's because of the plica circularis, okay? So it looks like coins, okay? And you see the coins, the line goes all the way through. So if we look at the next picture, again, central bowel, stacked coin appearance, couple of air fluid level. Okay, I don't really care if it's jejunum or ileum, that is not relevant. Okay, but you get the impression you're seeing quite a lot of bowel loops here, that this is maybe a little bit further along, so closer to ileum. And I'm judging that purely on how many loops I can see. Okay, but it's not a hard and fast loop. And this is just illustrating that stacked coin appearance. Okay, so now let's look at our large bowel. Okay, so we know the large bowel runs like a picture frame, up the one side, over the top, down the other side. And this is just an illustration of where we're seeing a little bit of distension over here. So important, look at the haustra. This is in contrast to the small bowel, which has that coin appearance. Haustra are these little indentations over here. Okay, and you see they don't cross all the way across the lumen. So why am I mentioning that? Because small bowel can get very, very distended. Then you think, sure, it's really big. Is this now big, large bowel or small bowel? Look at the bowel markings. Okay, if it crosses all the way like a coin, small bowel. If it doesn't, it's haustra, that is large bowel usually. And roughly you get an idea of where the bowel hangs, but you see how low down this transverse colon is hanging. So that is why where you are seeing the gas pattern does not always help you. Okay, so here again, we're looking at large bowel obstruction. We know our bowel goes up, across, and down, and this is obstructed transverse colon. Okay, I can see haustra here, and this is actually so stretched out that it's lost its haustra. Okay, so featureless bowel also associated with bowel obstruction, and that is very concerning because that means the bowel is overly distended. You don't even know what bowel it is. Okay, so this would be very concerning for a closed loop because there's no gas going past here, there's no gas here. Okay, so I would be very concerned about this loop perforating. Okay, because it can't discharge that way, it can't discharge back. All right. Sorry. And here, what are we seeing here? So this is the classic coffee bean sign. Okay, we all love our coffee, we need it to survive. Here's the coffee bean. Okay, we know this is an elderly patient. Why? He's had bilateral hip replacements already, and we see no air in the rectum. So this is most likely with coffee bean, we know it, sigmoid volvulus. Okay, so this whole thing is a closed loop. That's why sigmoid volvulus is a time-sensitive emergency because it is a closed loop obstruction. Alrighty. Again, yes. Okay, so what are we seeing here? Again, we know this is an elderly patient. They've already had bilateral joints done. We see a bit of a descending colon here going across the transverse. So this very big, very swollen thing is the cecum. Okay, a cecum more than 10 to 12 centimeters, depending on which textbook you use. I work on 10. If you measure the cecum and it's more than 10 centimeters, you are very concerned about imminent perforation, and that is a surgical emergency. Okay, so if you phone your surgeon with a large bowel obstruction, you will need to comment on the cecal size, and you just kind of measure it on the X-ray. Nobody's going to hold you to it. Okay, so there's our big cecum that's worrying there. Okie dokes. Now, questions, queries, and comments. Let me see what is happening with the chat. Righty-ho. Okay. In small bowel obstruction, is constipation also an issue? Okay, so remember the small bowel and the large bowel, they function completely separately. Okay, so it is not an issue, okay, because the large bowel is not affected. So constipation, not an issue in small bowel, because the small bowel before the point of obstruction is what is unhappy. Okay, remember after the obstruction, you get collapse. That bowel is empty. Okay, so it's the bowel that is proximal to the obstruction that is unhappy. All of the bowel after it doesn't really know what's happening. Okay. Okay, so someone here asked about adhesions. So they actually soften with time. Okay, so it's not to say that if you had your surgery 40 years ago that the adhesions are not going to be a problem, but it's just in terms of, as a surgeon, you don't want to go into an abdomen that was operated a month ago. Those adhesions are going to be very tough. There isn't good plain delineation between the bowel. So the chance of injuring bowel while trying to free the adhesions is very high. So you want the adhesions to actually mature, and if you have to go back into an abdomen. But you won't go and reoperate unless the patient really is warranting surgery. Just on the diagnosis of adhesions, you won't reoperate them based on that. Okay, signs and symptoms of impending ischemia. Okay, so it's very difficult, especially if it is not a site that you can see. So by that I mean, if you have the bowel stuck in inguinal hernia or an incisional hernia, you can actually get an idea of what's happening there, judging by the health of the skin, how much pain they have. If it is an internal hernia or adhesions, it is very, very difficult to assess the bowel. All you have available to assess is the general state of the patient. So are they becoming more dehydrated? Are they becoming more tachycardic? Is their lactate going up despite resuscitation? Because remember, lactate tells you that somewhere there is unhappy tissue. Okay, so unless you can directly assess where the problem is, like your hernia sites, it's very difficult to judge bowel ischemia. And that is also a problem if you had an incarcerated hernia. Remember a hernia that was stuck, that then reduced, either because it reduced on the way to hospital, or it was reduced at the peripheral hospital and is now arriving with you. You don't know that when they pop that bowel back in, that there's not a piece of dead bowel wall that they forced back into the abdomen. So unless there is deterioration of the patient, or that ischemic bowel perforates and declares itself, you don't know if there is ischemia. You just have to judge on the clinical picture of the patient or the presentation of the incarcerated hernia that you saw. Okay, here's a very good question. Pulmonary complications associated with bowel obstruction. Okay, so how shall we think about this? First, we need to think in an obvious mechanical way. All right, so if the abdomen is very full and distended, okay, it's not going to allow proper movement of the diaphragm. Okay, so the patient is going to lose a lot of tidal volume. Okay, they're going to lose reserve volume, and they will get basal atelectasis of the areas closest to the diaphragm, because there is not adequate expansion of that lung. So they're going to lose tidal volume. Okay, they're going to get basal atelectasis. They're not going to want to cough and take deep breaths because they're cramping, their abdomen hurts. So that is some of the complications. And then if you are vomiting and regurgitating this bowel content, very high risk for aspiration, even in an awake and alert patient, worse so if they have a fluctuating level of consciousness. So that is an issue. And yeah, I think that is basically the immediate complications. So your aspiration risk and the fact that you lose lung volume because of this distended abdomen, because the patient isn't breathing deeply. So those are very quickly a summary of the pulmonary complications. That's a good question, because remember, you need to treat the patient holistically. It's not just a small bowel obstruction. They have lung things, cardiac things. Remember, they can have cardiovascular compromise because they are dehydrated. Okay. And remember, with the vomiting and all of that, the electrolyte, if it is not the cause of the bowel obstruction, is definitely going to contribute, because your electrolyte losses are also marked. So they will go haywire, even if it wasn't the original problem. Okay, here's a very good question. Should a bowel obstruction patient always be referred to a hospital with a surgical team? Ideally, yes, because that patient may deteriorate acutely, okay, because he has a piece of ischemic bowel that we didn't know about, and now he suddenly becomes hypotensive and needs surgery now. If you still need to transfer him 200 kilometers to Tygerberg, that's going to be a problem. So the textbook standard answer is abdominal observations, conservative management for any surgical condition should happen in a hospital with a surgical team. Does it always happen in South Africa? No. But you, as a junior doctor being sent out into the periphery, you should always have a resource that you can call, be it at your referral hospital or a consultant on call, so that you can document, this is the patient's clinical presentation, this is your differential, you spoke to the surgeon said trial conservative, call me back tomorrow. Okay, if you have done that, then you have covered yourself. But ideally, yes, they should be in a hospital that has immediate access to a theatre. But again, from a practical point of view, sometimes referral hospitals are full and they will tell you to keep the patient and drip and suck and see how they do. But just make sure you document. Okay, all righty. Okay, very good question. Again, I love how you guys are giving me these practical questions, making me think. Okay, so here one of our colleagues asked, if you're working in a very rural hospital, there's no surgeon within 200 kilometers, how do you approach an emergency, be that an infarction or a perforation as a GP? How much time do you have to play with? Would you be held legally liable if you try to save the patient's life by performing a small open surgery? So remember, with surgical conditions, it's not a matter of a little bit of surgery is better than no surgery. If you're not going to do the correct surgery at that time, then by putting the patient through an anesthetic, maybe with a junior anesthetist, you are delaying and you are actually compromising that patient further. So unless you're going to do the proper surgery that they need in the right setting, doing a little surgery just to manage something is not really a good idea. So remember, with bowel ischemia, bowel perforation, what kills the patient? Hypovolemia kills them and sepsis kills them. So what can you do if you are far from a surgeon, you don't have an anesthetist, you can't operate, you can't do the right operation? You're going to ABC. Okay, you're going to make sure their airway is sorted, their breathing is sorted. If they become so sick because of that perforation or bowel ischemia, you will intubate them, you will ventilate them, and you will give them the fluid and inotropic support that they require. If you are concerned about bowel ischemia, bowel perforation, you do then initiate them on antibiotics, because the quicker you get antibiotics on board in those scenarios, the better the patient is. Okay. So at that point, it is the resuscitation that is going to save the patient's life. Okay. So fluids, blood if they need it, antibiotics, inotropes, and rapid transfer. Okay. To say how much time do they have, it depends on the patient. Is it a young, healthy patient with a hernia? Is it an old, very sick patient with a cancer that's now perforated? They are obviously going to cope with the perforation very differently. But doing a small little like backyard operation, not a good idea. You will actually be in legal trouble for that because you did not have the skills to manage it. You should have referred it. It is not your fault that the hospital is delayed or that the hospital is far away. You can only work within the resources that is given to you. So if you suspect that, you go to your ABC, you treat what you can, which is the hypovolemia and the sepsis, and you get that patient to a referral unit as quickly as possible. Okay, so don't do backyard surgery. Okay, here's a good question. African degenerative leiomyopathy, does it normally start at the large bowel and move to the small bowel? So that is the general pattern that we've seen. So they present with worsening constipation, abdominal distension. They look kind of like an adult Hirschsprungs, if that makes sense. So then we excise parts of the colon, they come back, more of the colon is descended. But that is not to say they can't present with esophageal issues before colon issues, but generally we see it work from the colon backwards. But very poorly understood, very rare. Okay, on hypokalemia, is a blood gas sufficient to identify it, and how to correct hypokalemia in the bowel obstructed patient? Okay, this is a very good question because hypokalemia is something you're going to see, especially in patients on diuretic. Okay, so yes, we do use the blood gas values to treat, be it high or low. We use blood gas values to treat. But remember, with hypokalemia, you need to think, why is this patient hypokalemic? Is it an acute or chronic thing? So remember, you can only lose potassium through the top or through the bottom. Okay, so do they have a history of diarrhea? Do they have a history of vomiting? All right. If they have that, then you want to replace it. How are you going to replace it? So it's IV replacement. Remember, the bowel is angry and obstructed. It doesn't help to give oral replacement. We're just going to throw it out. So potassium replacement is something very important. Remember, it is very, what's the word, very caustic. Okay, so you need a nice thick IV line, and it needs to be flowing very well because it actually burns, like it hurts to give patients potassium. So you cannot give more than 10 units or 10 millimoles of potassium over half an hour. Why? If you were present for our previous discussion, the heart is very sensitive to IV potassium. So when they give them a lethal injection, they actually give them IV potassium just for interest's sake. So normally how we give it, we give 20 millimoles of potassium. So that is 1 plastic ampule. It's potassium phosphate usually. We give, no, I'm wrong, it's potassium chloride. We give 20 millimoles of that over 4 hours IV. Okay. If they are having dysrhythmias, then you will give it faster. Again, not faster than 10 millimoles per half an hour. But that will be with ECG monitoring and only if they are severely unstable because of the hypokalemia. But in your bowel obstructed patient, to give 20 millimoles over 4 hours, that's quite safe. And you give it, you want to give it in a liter, okay, because then it dilutes, it doesn't burn the vessels as much, but also bearing in mind you don't want to fluid overload your patient. So you want to make sure they are excreting well before you go in aggressively with your fluids and your electrolyte replacement. Okay, righty-ho. Okay, good question. What antibiotics would you choose for a perforation? Oh, someone just did gynae, ampicillin and gentamicin. Those are not bad, but most of our patients haven't had a lot of exposure to antibiotics. So just keep it simple and go Augmentin, really. You don't need to go Augmentin and Flagyl because Augmentin covers the same anaerobes as what Flagyl does. So just IV Augmentin. If they are delayed or chronically ill or have had antibiotics or have other health conditions going on, call your referral hospital and ask. But also remember, in district hospitals, you won't necessarily have good access to all of the antibiotics because it's controlled. So just a good shot of Augmentin will give good coverage for the gut. So happy with that. Okay, I hope I've answered everybody's questions effectively. Are there any other questions? We seem to come to the end of the submitted questions. I want you to understand the two categories of bowel obstruction, small bowel, large bowel, why they present differently, okay, and the different causes. So again, no peristalsis. Is it a content issue or is it a tube issue? And if you can broadly remember those three things, then you should be able to figure out in large bowel and in small bowel what the causes can be. Again, your approach, you want to know the age of the patient. You want to know how they presented. So explore what they are complaining about. The history, surgical, medical, family. Family, you want to ask specifically about a history of cancer that the patient had or that family members have had, especially relevant in your colon cancers. And then your examination. You want to confirm based on what you're already thinking, is the small or large bowel, and then your x-ray should hopefully agree with you. Okay, awesome. No other questions. I hope I've adequately addressed the hypokalemia, the pulmonary stuff, the management and transfer. You guys asked really good questions. I'm very happy with that. It shows that you're really grasping the concept. Yeah, so I'm going to just ask Tianka to sign off for us. If there's any other stuff, please talk to your SAS members. You've really got an amazing team this year. They're doing great work. Other topics you want in surgery and trauma, please let them know and we will be happy to organize that for you. Awesome. That's me done.
Okay, thank you, Dr. Changfoot, once again for doing this for us, and thank you everyone for joining us. Just a reminder, if you want to see our previous SAS talk that was given on crush syndrome, this is on our SAS YouTube channel. Thank you and have a good day.
Awesome. Bye, guys.
Bye.